Welcome back to the fold, Malay. We are happy to have you with us, and Dr. Prasad has also joined, I believe. Dr. Prasad, you can unmute yourself and switch your video on.
Yeah, good evening.
Good evening. Good evening.
Yeah, good evening.
Good evening. Good evening. Yeah.
So, welcome, Dr. Prasad. Welcome, Dr. Dave. We are back here, friends, with our new edition of the Postgraduate Psychiatry Lecture Series. As we always do, we have brought to you today a very, very interesting talk on the neuroscience of and neurobiology of addiction. And who better than amongst the most astute clinicians as well as a very, very brilliant academician to bring it to you, Dr. Malay. He is my friend, philosopher, guide, teacher, what have you. So I couldn't think of a better person than he's been on this forum often enough for you to know about him, but I will leave that to Dr. Prasad to introduce him. Dr. Prasad, welcome to our fold. This is the first time you are with us. So
Yes.
That you could take the time despite of the fact that you are in the midst of annual conference at Odisha right now at Bhubaneswar, but thank you for making the time. I have the proud privilege of introducing Dr. Prasad to you. He is a consultant psychiatrist and a dear friend at Nashik. He has been the ex-associate professor of psychiatry at the MVP Medical College and Hospital. He's been a postgraduate teacher and guide for the MUHS for many years now. He is a consultant at Sujata Birla Hospital and Medical Center. He is also the Indian honorary psychiatrist of Indian Security Press and Currency Note Press Hospital at Nashik. He has been the president of the Nashik Psychiatric Society, and he is an alumni of the BJ Medical for his undergraduate and postgraduate. He's a multi-dimensional guy with interest in music, in sports, in reading fiction, non-fiction. I know of his love for music. On various forums, we've had him pull out gems from the past. So it's a very, very beautiful side of him that we've got to know the last few years. But then he is here today in the capacity of a senior consultant and a very well-read psychiatrist. So welcome to our fold, Dr. Prasad. And I hand over the proceedings to you. And I shall be back at the end of the day. Thank you.
Right. Thank you so much, Rashmin. I mean, you've been effusive in your introduction. I'm a simple guy, but the star attraction of today is, of course, Dr. Malay. I mean, all of us, in fact, love to listen to his lectures, specifically with his beautiful command over the intricacies of the human mind. And so much so that the world psychological is slowly taking a beating, when it comes to the brain beating everything else. So I think I won't come in the way of Malay, and I think all of us know Malay so well. He is an extremely approachable and an extremely knowledgeable person. It's a pleasure having him or chairing a session where he can, of course, expound on the intricacies of neuroscience. So over to you, Dr. Malay. I won't take too much time. I think we'll straight away go on to the lecture.
Thank you, Dr. Prasad, for the kind words. And I hope I don't disappoint anybody today. So, neuroscience of addiction, let me share my screen. Sir, whenever it's 5:10 now, so maybe around 45 minutes to 50 minutes, just let me know.
Sure, Malay. Take your time. There's no rush.
Yeah. Where is it going now? Is my screen visible?
Yes, Malay.
Okay, fine. So we'll be talking on the neuroscience of addiction as we understand addiction in the first quarter of the 21st century, or rather we should, the way it is. A brief review of what we know. And since it's a review and it's brief, I'll not be covering everything in details because it's a huge thing. And secondly, this is evolving neuroscience. So what happens is that if the same talk is taken, let's say after 5 years, or by somebody else who has read something more, something else, there might be additions or subtractions. Some things might not really have stood the test of time, so to say, and would probably be out of the window. But till then, what we know and what we need to understand, I'm just giving you a brief snapshot of that. So what are we going to look at in this presentation? Today's topic, first of all, why the need for neuroscience or neuroscientific jargon or things like that. What is the concept of addiction as we used to understand and as we should be understanding now? How does addiction develop? The stages of addiction, the systems involved, basically the chemistry, the chemical systems involved in the process of addiction, and how does the progression happen? Right. Now, all of us know that psychiatric disorders, psychiatric illnesses, and especially addictions are vulnerable to a lot of stigma. And this stigma is not only from the patients themselves or from the relatives of patients or caregivers, but rather from everybody in the medical field also. Every branch, every other specialist is not really gung-ho about addiction. It's kind of looked down upon, and to some extent there is stigma regarding addictions in our specialty also. Now, this stigma comes from the fact that, well, we do not look at addiction as a disorder. The first thing that strikes when we are faced with somebody who is battling addiction is quote unquote willpower, quote unquote morality, quote unquote look at your family, what's going to happen if you keep on taking alcohol, liver will fail, and so on and so forth. And that is where the stigma comes in. We have got n number of therapies, so to say, 12-step therapies, and so many things, motivational enhancement therapy, where either I leave it to God and I take one day at a time to change myself, may work for some people. Motivational enhancement techniques where over a period of time, with subsequent sessions, there has to be a change in my motivation to bring about a change within myself, may work with some. But then, given all these approaches and given the so many approaches that we know and we do not know about, still there is a lot of failure. Many patients are in and out of our services, and they, in medical terms, do not get well. The problem keeps coming and going. Somebody would have been sober for 10 years and then start again, and then down that same slope. Whenever a disorder is not understood, whenever a disorder is partly understood, whenever a disorder has no satisfactory explanation and non-satisfactory treatment, is always going to be vulnerable to stigma. So just by saying that we need to be aware of addictions doesn't make it go away and doesn't add anything more to removal of stigma. When we are fighting stigma, we need to treat disorders. We need to show that disorders are treatable, and we need to show that treated disorders, when they are under control, when they are managed well, can enable a person to live a normal or an almost normal life. That is where the stigma is. So the point is that unless and until we look at addiction from a different point of view, in the sense we look at all these things, till that time there is going to be some stigma or the other, and we owe it to our patients also to give them understanding of why these things happen. The second point is, if we view it as a disease, there is a medical model, and that is what we are going to talk about, the neuroscientific or the neurobiological model. So is it a disease? If so, where is the lesion? The commonest thing that can that others, non-psychiatrists or the non-scientific people would tell you is, show me a lesion. There is tuberculosis, there is a demonstrable bacterium, which is mycobacterium, which clinches the diagnosis. Something else, well, there is some image change, a change in the imaging or a biochemical parameter. What happens with this? Well, we do not have that kind of data. But what does happen is that we have started accumulating imaging data as to what happens over the course of any addiction. What are the structural changes, especially changes in the white matter or functional changes that can happen in the brain of patients who suffer from addictions. So we are accumulating data, but it is not that there is going to be one lesion or let's say one area of the brain which is going to be involved as a diagnosis for to kind of highlight the concept of disease. But what is definite is that addiction disorders are highly heritable. A family history of addiction in any one of member of the family makes the subsequent generations highly vulnerable to addiction and other kinds of disorders. And this is demonstrable time and again that addiction disorders are highly prevalent in families. Now, what is this concept of addiction? So addiction is always risky or hazardous substance use, meaning the quantity and frequency are the indicators of consumption. Very high quantity, very frequent consumption is risky substance use. As defined in DSM-5, substance use disorder is now classifiable into mild, moderate, or severe. Then there is another concept of addiction. So first one is risky substance use, which is more kind of an observable phenomenon. SUD, which is a diagnosis, a DSM specific diagnosis. Addiction, where people suffer, where people have persistent difficulties with self-regulation of drug consumption, means there is some loss of control. This is a conceptual definition. Now, when we look at this above three, there'll be high risk individuals, means people who have a higher quantity or frequency of consumption. Of this high risk individuals, a small subgroup will eventually meet the diagnostic criteria for SUD. That is the second point here, second definition. And among these who have an SUD, a further group would be considered to be addicted to the drug. Means there will be people who will be using high quantities and of something more frequently than others, so that would make it risky. Some people will meet the criteria for SUD, and some people in that SUD or in risky substance will be conceptually addicted to the drug, as we understand the concept of addiction. So we have this kind of a diagram here. So we have this risky substance use, the whole group of people who are using the substance in a risky manner. Some of them will meet the criteria of substance use disorder. This is where probably they'll come to our notice in our clinics, will be brought by relatives, and will be given a diagnosis according to the criterion. But actual process of addiction or the vulnerability to addiction or what we are going to talk about today will be demonstrable in a subgroup of this. Now here, there is no outline like this black. So this is porous. This is a concept, and this could either, this circle could either become bigger or smaller. So this is where we start. Now, the idea of highlighting this is that this whole thing is not addiction. So anybody who comes to us with alcohol use twice a week, 2 pegs a day, may not really have an addiction problem. Might be a risky substance use. Might be for him a little bit of a binge. So would get diagnosed, but may not be addiction. Because there is no loss of control. The concept of addiction is loss of control. So how do we define addiction? It's a chronically relapsing disorder, yes, that we all know. There is a compulsion to seek and take the drug, yes. Loss of control in limiting intake means once it starts, it kind of keeps on increasing. So there is loss of control. I cannot limit my intake. And there is an emergence of a negative emotional state when the access to the drug is prevented, which can manifest as irritability, dysphoria, anxiety. But what is also more important, and what we have started understanding in the last 2 decades, is this one. whatever we have talked here in these 3 points, drug, the word, should be replaced, can be replaced by many other things. For example, food, certain kinds of foods, certain kinds of behaviors, and that is where the spectrum of addiction becomes very broad. It is a process which not only involves substances or chemicals, but involves many other things, our behaviors, our likes, our dislikes. When they get out of hand, they can become addictions. This is actually the core understanding of addiction. It is not limited to a substance. If somebody is taking alcohol and is not taking alcohol, doesn't mean that the addiction has gone away. The vulnerability remains, and we'll see how. So what are the stages of addiction? This is how kind of we have understood, or we are understanding addiction with the help of this model. So this model has been given by Koob and Volkov. They are authorities in the field of addiction medicine, and they have given a comprehensive view of a model of incorporating what are the changes that happen in the brain when it comes to addictions. So we'll go through this model in brief. The model is this. These are the areas of the brain that are highlighted in different colors. And this is basically a diagrammatic or a kind of a chart-based representation of what happens. So we have got 3 colors. We have got a blue color, we have got a red one, and we have got a green one. And similarly, if it is laid out on flat paper, there is a blue part, there is a red part, and there is a green part, which moves from lateral to medial. It looks that way, but actually it moves from bottom to top and out. So it will move along the brainstem laterally and out up to the cortex. So how it moves and where it moves is not that important, but what happens is important. So we'll take one component at a time, and let's start with that first component, which is the blue one. Now, what is this blue component? The blue component, if you look at it and if you can make out, shows reinforcements, habits. So what is this stage? This is called as the binge intoxication stage. Here, binge and intoxication do not mean the kind of patients who are brought to us in an intoxicated state. Means they have taken a lot of alcohol or they have taken a lot of something and then they are brought to us. No, that binge intoxication is the amount frequency. This binge intoxication means the pleasure that is derived out of taking that substance or doing that thing. So remember, even if I'm using some drug as an example, we are talking of anything that goes into this circuit. So it could be a behavior, it could be an activity, it could be anything. So in the binge intoxication stage, a neutral stimulus becomes associated with drug availability. Means if I have taken alcohol, let's say once, in the company of friends, at a party. Now, alcohol is the drug, but the neutral stimulus associated with the drug is meeting people and partying. So when meeting people and partying becomes associated with alcohol, right? This is what happens in the binge intoxication state. Means, let's say I have had the pleasurable effects of taking alcohol. What changes happen in my brain will now make me want alcohol whenever I am faced with a neutral stimulus. So the next time I meet friends or go to a party, I would like to have alcohol. The third time I go to a party where there are people and friends, I will ask for alcohol, and it will go on till a point that I'll attend parties and meet friends only if there is alcohol. So the binge intoxication stage means that there is going to be pleasure, but not only the pleasure that comes from taking that substance or doing that activity, but the ambience around that, the situation around that, the circumstance around that also becomes associated with that pleasure. So a neutral stimulus becomes associated with drug availability. This is called as incentive salience, and it promotes habit formation. This causes excessive drug seeking. No, I'm meeting my friends, that's the idea, but actual thing is alcohol. Now, the parts of the brain that subserve this stage is nucleus accumbens, shell and core, that is the dorsal striatum. So if you look here, this is the dorsal striatum here. So nucleus accumbens will be here somewhere, right? So this is that blue part. This whole circuit is the area of the brain that is involved in this binge intoxication state. So if you look at it, the reinforcing happens in the nucleus accumbens, shell and core. Okay, the nucleus accumbens is on the dorsal striatum, or let's say at the base of the forebrain, around that area, and it is divided into two parts: the shell and the core. Core is the central part, the shell is the part surrounding that, and the dorsal striatum. What are the neurotransmitter systems involved? There is an increase in dopamine, glutamate, and opioid neuropeptide transmission. Okay, so dopamine, glutamate, and opioids. So the acute phase, or let's say the acute stages of addiction, start with an increase in these. Okay, and with these changes, a neutral stimulus becomes a reinforcer in its own right. So then it's no longer friends and party. It could be anybody. I can go to a bar and have, because there are people around, I feel like taking alcohol. So incentive salience is the motivation for rewards derived from one's physiological state and previously learned associations about a reward cue. This is what I had mentioned earlier. This is basically at the root of cue-induced drug seeking. One of the strategies when we are managing addictions is how is that person going to handle the cues? You cannot tell the patient to just stay at home, not go out, not do anything. But how are these cues to be managed? Because these cues, they become so firmly fixed that they can trigger the whole behavior again and again. And once it goes again and again, this habit, rather this taking of a substance or doing something, becomes a habit like compulsive behavior. Means this has to be done. This is stage one. That was a blue one. What is the second stage? Is the red one. This is called as the withdrawal or the negative effect stage. Okay. Now what happens here? This stage is characterized by chronic irritability, emotional pain, malaise, dysphoria, alexithymia, states of stress, and loss of motivation for natural rewards. So what happened in the first stage is that reward was there, but that reward got paired with the ambience or the situation or the circumstance. And then that situation, ambience, circumstance became a cue. So a person would use that cue to get the pleasure. In this, what happens is this cue is set, but that pleasure doesn't come. I had taken alcohol, I felt good. I had taken nicotine, I felt good. Now the ambience tells me, prods me to take that, I do that, but I do not get that pleasure. This is called as the withdrawal or the negative effect stage. So when I do not get that pleasure, then all these things will happen. I am taking it, my ambience tells me that is the cue, but I'm not feeling happy about it. I feel unhappy. I do not feel okay. I do not know what I feel like. I feel stressed, irritable. And in many patients, we have seen that the relatives say that when he or she doesn't get that, what he or she wants, they become very aggressive and violent. This is the withdrawal or the negative effect stage. Now, again, this withdrawal doesn't mean that I have stopped taking alcohol and within 12 or 16 hours that withdrawal symptoms start in the form of tremors and so on. This withdrawal means that state when for a period of time, the substance is not available, right? And so this can also mean that, let's say we have treated somebody for withdrawal The withdrawal management is over. And now there are days or maybe months for which the patient has not taken anything. But still he will feel this. Why? Because that is not there. On the top of it, the relatives would be happy. They would say, no, he or she is not taking anything. He's clean, attends work. But when you talk to the patient, they'll feel, I can't describe it. I know I'm not feeling okay. Some of them will feel depression. Some of them will come up with a lot of physical complaints, signaling that something is not okay. Then you wonder, we have treated the addiction, so to say, but what is this happening? This is the withdrawal or the negative effect stage, right? Emotional pain, two things. We often, or maybe on a daily OPD, very frequently, we see patients with a lot of pain syndromes. Now, this pain, when they go to an orthopedic surgeon or somewhere else, they'll say there is nothing, it's all in your head. The reason is, well, there is no demonstrable, infection or injury, but the pain is there. And this pain, we need to understand, is basically any pain has got a more stronger emotional component than a physical component. And for our patients, for psychiatry patients, the emotional component is very high. Okay, so the pain is as perceived as if there was some injury or some damage or anything, something like that, but the quality remains the same. So we understand, and we need to also kind of make it very clear in our heads, this pain that we talk about in anybody, even if there is a physical cause involved, is more emotional than physical. So basically, there are many people who would like to classify pain as an emotion rather than a sensation. Okay, so what are the areas involved? One is this extended amygdala. This extended amygdala is basically amygdala plus a lot of other areas. One is the bed nucleus of stria terminalis, the central nucleus of the amygdala, and a part of the shell of the medial portion of the nucleus accumbens. Now, in the first part, we talked about both the core and the shell of the nucleus accumbens. Here, some component of nucleus accumbens is there, and this is the connection between the areas which subserve that binge intoxication stage as well as this stage. This is the medial portion. These projections of the extended amygdala go to the hypothalamus and brainstem. Because they go there, they produce this pain and this kind of things, along with the physical component. The neurotransmitters in the previous one were dopamine, opioids, and glutamate. Here they are CRF, norepinephrine, and dynorphin. It's an opiate, it's a monoamine, and CRF. Now, whenever CRF starts getting involved, it produces physiological changes similar to those of stress, right? We'll come to what exactly happens a little bit later on, but this is how it is. So from the first stage, which is driven by pleasure, to a second stage, which is driven by no pleasure. On the contrary, there is negative effect or all these things. So this binge intoxication stage triggers what? Diminished reward function. So they do not get the same pleasure. Increased brain stress activity. Why? Because CRF and dynorphin are getting involved. Third, deficits in executive function via glutamate, GABA, dopamine neural networks in the prefrontal cortex, right? Why? Because anything that has to do with reward, perception of reward, no reward, has to be processed. And for that processing, everything has to be, all this information has to go to the higher centers, that is the DLPFC or the prefrontal cortex, for a decision to be taken as to what is to be done. And because this whole system is kind of getting tuned towards lack of pleasure from a reward situation, the processing is also not correct or accurate, and that is where there is a dysregulation because of all these things, and therefore there is a deficit in executive function. When there is a deficit in executive function, I cannot control what I need to do and what I need not do. So there is a perpetuation of dysregulation of reward and stress function and compulsive drug use. So first stage starts compulsive drug use. Second stage kind of pushes it more. Okay. We come to the third one, which is the preoccupation or craving stage in green. So we have seen the blue one, pleasure, blue going to red, pleasure, now no pleasure, but negative effect, and from red to green. So this preoccupation or anticipation stage, this is something like, once this is set, means this whole process is set. Once this is set, you cannot easily go back to the previous no exposure state. Okay. So this is the key to relapse. Why do things keep on happening again and again in spite of our best treatments? So executive control over incentive salience. Incentive salience, that is the purpose of first stage, the blue stage, is essential to maintain goal-directed behavior. Unless and until the situation or the cue is not sufficiently attractive, will not keep on doing it. Okay. So how much to act on something or not act on something is executive control. Executive control is higher up. Cue induced craving appears to involve activation of circuits. Okay, this is what we saw. These cues that are associated with drugs and elements of non-drug addictions produce activation of the prefrontal cortex. That happens in the previous one. Deficits in executive function that are reflected by decrease in prefrontal cortex activity interfere with decision-making, self-regulation, inhibitory control, and working memory. So all the cognitive functions that are regularly okay and will kind of guarantee a healthy behavior now become problematic. This is what happens in anticipation stage. Okay, and how does it go? So process of condition information is in the basolateral amygdala and processing of contextual information of the hippocampus. So basically emotional memory coding, emotional memory gets coded in the amygdala and the hippocampus, this connection. So first is emotional memory. So whatever is happening to me, whatever emotions I am feeling are now kind of not only there for that moment, but they are getting stored, right? Anything that requires a decision making is going to borrow from the stores of memory. This is the basis, storing of experience, right? Executive control depends on the PFC and includes representation of contingencies. What if this, what if not? Representation of outcomes. ये भी हो सकता है, वो भी हो सकता है. Value, how important it is, how less important it is, associated with drugs. So all these parameters regarding that, this are given by the prefrontal cortex. So when the emotional memory is not a happy one, all the outcomes, all these things become negative. Activation of the orbital and anterior cingulate cortices, temporal lobe and amygdala. This will be for the mood states and behavior states, again memory and emotions. Multiple neurotransmitters get involved because now everything is going higher up for processing. So glutamate, GABA, norepinephrine, substance P, vasopressin, NPY, endocannabinoids, nociceptin, and multiple. If you look at the review, this is 2010. So this is 12 years back. Even though this is a basic review, it involves a lot of things that we need to know. But after 12 or 13 years down the line, we still have much more added to this in terms of more names as well as a more in-depth understanding of each of these systems. So to sum up this model, what do we have? We have got three stages: binge intoxication, withdrawal or negative effect, preoccupation, and anticipation. There is an impairment. What? First of all, an impairment in incentive salience, reward deficit, and stress surfeit. Reward deficit means I am not able to appreciate the reward of this. Stress surfeit is because of that I am unhappy. There is a stress. CRF is getting involved. Preoccupation, anticipation, problematic executive functioning. Now, once this is set, what actually happens when this thing keeps on moving, keeps on happening again and again? We looked at a lot of neurotransmitter systems. These are molecules. These molecules also keep on working more or less in an improper fashion. Since they are neurotransmitters, they are going to have an effect on the synaptic systems. We know that any synapse which keeps on working, becomes stronger, especially when it is overworking, let's say in the hippocampus and amygdala. We just looked at that one slide before here. the memories get laid. That is what we know which as long-term potentiation, which is the kind of synaptic plasticity. Once this is set, it is not very easy to get back to a non-plastic state. Okay. And this happens in a lot of circuits because there are so many areas here. There are so many networks here. So many small things happening here. So once this circuit is in progress, once these processes are in progress, molecules functioning changes, synapses become stronger, the ones which we do not really want to be. And these neurocircuits undergo a lot of plastic change, which is going to last long. This is the model of addiction. And as I said, whether it is a drug, whether it is an activity, whether it is a food, anything can get into it. Now, we need to understand one thing. This process happens in everyone, but all of us are not addicted, so to say, to alcohol, so to say, to any kind of behavior. Why? Because we have got healthy parameters when it comes to the working of these systems. If the systems to start with are unhealthy, again, a bit later on, when the systems are unhealthy, there is some fault, then some problem like this can set in. If they are okay, the systems will work fine. There will be no loss of control as described in this thing, in this model. So all these structures and all these systems are there in all of us. But in some vulnerable people, these systems work over time or under time or improperly, thereby setting an addiction behavior. So what are the different systems in addiction? By that I mean, what are the different neurotransmitter systems? The first one that we talked of was dopamine and nucleus accumbens. So unless and until this nucleus accumbens is overactive, right, it is not going to lead us to that incentive salience. Incentive salience all of us have. Why? Because we like something, we do not like something. But when we do not get the things that we like, we may be upset for a while, but then that's not a problem. But in those individuals where nucleus accumbens is, let's say, very highly sensitive to change, or under a lot of influence, stimulatory influence of glutamate from prefrontal cortex, amygdala, hippocampus, or ventral tegmental area, including dopamine, we are going to have a hyperactive nucleus accumbens. And that is where the first stage will come, the stage of incentive salience or binge intoxication stage. So this is the first symptom, and this is the first neurotransmitter. Why? Because when it comes to dopamine, dopamine is necessary. I mean, of course, from the Parkinson's disease point of view, we know that it is important for smooth movements. But how is it important? And we also know that dopamine levels, when they are very high in the midbrain and the mesolimbic pathway, we get positive symptoms of psychosis. Yes, but what does it normally do? Normally, dopamine is necessary to maintain a healthy state of salience. Salience means to pick up things that we would like to do from our environment. There are thousands of things, but all of us are not interested to the same level in all the 1,000 things. I would like to do this. Dopamine is necessary. So dopamine is necessary for salience, to pick out interesting things, to continue with whatever you have picked up. So salience and motivation, that is dopamine. Normally, dopamine works in, let's say, two fashions. One is there a sustained level of dopamine is necessary. And on top of that, there are phases. So one is a tonic activity, flat activity or flattish activity of dopamine. And then there's a phasic up and down activity of dopamine. So if my dopaminergic system is not functioning very well, let's say there is a low dopamine tone. So tonic activity is low. I may not have good motivation. I may not have proper salience activity. Suppose I take cocaine. What will happen? It will give me a high phase. It will shoot up my dopamine like anything. This will make me feel good because for that period of time, my tonic dopamine will be high, but the phase will be very high, right? And that is where an addiction can set in. Any bursts of dopamine in an abnormal state can lead to an overactivity of NSC and that binge intoxication and the subsequent stages. This is how dopamine works. Apart from what we know in movement, in psychosis. The other system that we mentioned a couple of times is the opioid system, the endogenous opioid system, of course. Endogenous opioid system, lot of basically endogenous opiates, enkephalin, endorphin, right? These are endogenous opiates. Now, what do they do actually? When we talk of opioid systems, the only thing that comes into our mind is opium and related products. What do they do? How are they acting and things like that? But it has got certain value. In fact, it has got a lot of value as we understand it in these days. 3 types of receptors: MOR, that is mu opioid, kappa or K opioid receptors, and delta or D or delta. There may be others. There are others also, smaller ones, may not be that important, but these are the most important ones. This interaction between, let's say, mu basically maintains a good, happy mood state, euphoria. So anything that works on mu can cause euphoria, make you feel good, make us feel good or very good. Kappa opioid, okay, if it is kind of overworking, it might produce dysphoria and negative effect, and activity which is kind of opposite mu opioid. So in normal people, there is something called as a hedonic tone, means a mood tone, how we are feeling. Most of us feel okay. So let's say there is a balance between mu and kappa activity. What does the delta do? Delta has got again some effects which are kind of opposite to kappa. Low anxiety, positive effect. So this is against dysphoria and this is against positive. So again, when a proper mood state is necessary, this balance is needed. Now, what have we found out when we look at those 3 models? Binge intoxication, mu opioid receptor. Why? Because now we are not getting that euphoria. So adaptations to the drug, low reward, and mu opioid adaptation means now the mu doesn't get stimulated as much as, let's say, in a normal person. So euphoria is not there, binge intoxication. What happens in the withdrawal state, the second one? Increased dysphoria, low mood, high anxiety. So increase in kappa activity. Dynorphin, another endogenous opioid, this activity. And less of DOR, more of this, less of this. So basically there is a negative mood state. In the last stage, preoccupation, anticipation, everything may be involved, because it's not only a mood state, but the learning and all. So this is how roughly at a glance the opioid receptors or the opioid system is involved. Now, if you look at it this in more details, NSC is nucleus accumbens, VTA is ventral tegmental area. Okay. So dopaminergic activity, but we understand now that it's even in a dopaminergic neuron, there are a lot of other activities also that are going on, right? And dopaminergic neurons are under various influences. This is GABA in pink. Okay. We have got glutamatergic too. So GABA and glutamate, definitely we need glutamate to activate. We need GABA to put brakes. So there is a kind of a optimal activity here. Okay. But if you look at GABA, it comes under opioid activity here. If you look at glutamate, also MOR is here, right? If you look here, if you look at this, where is it gone here? If you look at this pink receptors here, this one pink lines, okay? So GABA and glutamate, though they are basically, kind of holding the reins of dopaminergic neurons here. This increases, this decreases the activity. What are the other influences on them? We have got opioid receptors on both, the yellow ones. We also have this pink one here. which are endogenous cannabinoid. We'll come to that later on. So a very simple system, one monoamine, stimulatory effect, inhibitory effect, makes a balance, but there are superior controls over them also, opioid and endogenous cannabinoids, right? And also here cholinergic. So this is how there is an integration of systems when it comes to dopamine and opioids. A quick look at what other things we know that contribute to it. Now, we had a mention of the endogenous cannabinoid systems. This is something which we are understanding more in depth now. We have got a lot of papers about cannabidiol, which seems to be having a therapeutic effect. We had drugs working on the endogenous cannabinoid system called as rimonabant, which failed. It didn't work out very well. CB1 antagonists, let's say. So what is this system of endogenous cannabinoids or endocannabinoid system or ECS? Now, we are not going to get into details, but it is a very complex system. Okay. There are many agonists involved, mainly two of them, 2-acyl-glycerol, okay, and anandamide, APA. These are the two main agonists, okay, but multiple activities over multiple systems, whether it is serotonin, whether it is dopamine. We saw that dopamine thing there, okay, multiple types of receptors, predominantly CB1 and CB2, cannabinoid receptor 1 and cannabinoid receptor 2. So we have got a system where there are primarily two agonists, 2-acyl-glycerol and APA, that is anandamide. Now, two agonists, CB1 and CB2, two main receptors. But what happens is, this whole system is not actually known as ECS, but like we have the human genome, we call it and we understand it to be an endocannabidiome. There's a lot of things combined. And why do we say that? Just in a moment. So we have got two receptors in this system, CB1R and CB2R, which are G protein coupled. CB1 is excitatory presynaptically and inhibitory postsynaptically. Okay. And what does it do? It is involved in mitochondrial function management, synaptic plasticity, proliferation of adult progenitor stem cells. Okay. Different kinds of activities which has nothing to do with cannabis intoxication. And CB1R and CB2R receptors are, as I showed you in the diagram, they are present on a variety of other neurotransmitter related synapses. That is this is CB1. So what does it do basically? On the membrane, CB1R reduces intracellular calcium, so it is inhibitory. But this CB1R also is present inside the cell organelles like mitochondria, where it reduces mitochondrial activity. On the lysosome, okay, where it increases CA, so it increases lysosomal activity, lysosomal breakdown. On endosome, where it has an effect on beta-arrestin mediated signaling. So membrane effects, intracellular effects with CB1R. CB2 is not very strongly expressed in adults, seen earlier during the development, but low levels in healthy neurons, and have the exact opposite effects of CB1, mostly found in glial cells. So they are going to kind of subserve the function of neuroinflammation, mostly that, right? But what makes the system very complicated is, see, normally any neurotransmitter will have some enzymes which are responsible, so mostly one enzyme that is responsible for the production of that neurotransmitter, one or two enzymes that are responsible for the degradation of the molecule. Here, everything is multiple. So endocannabinoid degradation, whether it is 2-AG, diacylglycerol, or AEA, that is anandamide, Okay, they are broken down by a number of metabolic pathways, number of enzymatic pathways. And those number of enzymes will also degrade other things. So it is very complicated. So when it comes to degradation, when it comes to even biosynthesis, both this anandamide and 2-AG are produced by several pathways. It's very different from the conventional way in which a neurotransmitter is produced and stored in the cells, in the vesicles. Usually one pathway. Here there are multiple pathways. Even promiscuity of targets, they just don't act on those CB1 and CB2. So anandamide, for example, activates multiple other receptors. Okay, multiple receptors like TRPV1, PPAR alpha and gamma, GPR55. This kind of receptors, we knew it, but we didn't know it till some years back that they're associated with the endocannabinoid. Okay, so multiple effects, far-reaching effects. Other cannabinoid-like mediators are also there, which act on this system. So even this system is not specific for anandamide and diacyl 2-AG. Allosteric modulators, there are other compounds which kind of change the functioning of CB1 and CB2. So that is what makes the system very fascinating, very complicated, and extremely difficult to manipulate, because if we, let's say, block one enzyme, maybe that is not enough, because there are other enzymes also involved in the picture. Also, now we understand that when it comes to the gut-brain axis, the endocannabinoid is like, it has a lot of activity, because this CB1 and CB2 are not related to the brain only. They are present everywhere in many cells, including those other smaller receptors also, TRPV1, PPR alpha, and so on. Right? So how does this affect the dopamine? Now, we are interested in two things. One, whether anything has an effect of increasing the incentive salience, whether the dopamine will increase in the first place, because if that doesn't increase, then maybe the addiction will not set in. And secondly, what maintains the addiction once it is set? So the endogenous endocannabinoids, that system through CB1 mainly, because as I said, CB2 doesn't act very much, mostly neuroimmune activities and neuroinflammation. Okay, this has an effect via two things. One is CB1 can inhibit GABA, because the cellular effects of the membrane effects of CB1 is less calcium goes in. So if CB1 is there on the GABAergic neuron, it may inhibit GABA. If GABA is inhibited, the control over dopamine production is loose, so more dopamine is produced. So if CB1 overacts, GABA underacts, dopamine is more. That is one way. Second thing is, again, CB1 is also present on glutamatergic neurons. Glutamate system is again very complex with a number of receptors and not very clearly understood metabotropic glutamate R5 receptor. So once this thing gets stimulated, again it directly stimulates dopamine production. So an increased CB1 activity reduces GABA, increases glutamatergic activity. The sum total is increased dopamine production in the ventral tegmental area, nucleus accumbens, and so an increase in the chances to develop incentive salience. Okay. Now this is one diagram again which is similar to what we have seen before. Two components. We have got a dopaminergic neuron here. We have got a glutamate. We have got a GABA. On glutamate we have this one, this neuron. This is opioid. This is endocannabinoid, CB1. Okay, so this is MOPR, mu opioid, CB1. So both glutamate and GABA have got mu opioid receptors and endocannabinoid CB1. Again, this is a fine balance. Glutamate stimulates dopamine, GABA inhibits dopamine. But this mu opioid can actually inhibit this. This can stimulate this. So even these neurons have got a double feedback kind of activity. And then acetylcholine also contributes to dopamine neuron activation at the VTA. So a complex system of multiple things, and this is actually simplified, which can lead to an enhanced VTA activity. Means this VTA is sensitive. Something comes along its way, it can give a pulse, and that phase of dopamine, which is a rapid shoot up, can lead to the development of incentive salience. So whatever was the picture, basically this is a kind of a simplified diagram, but again, it is, you need to really trace the arrows. So we have got the basolateral amygdala, BLA, ventral tegmental area, VTA, nucleus accumbens, and cortex. And all the action seems to be happening in the medium spiny neurons, this category of neurons, okay, which seems to be the center of all activity, whether it is the activity of a substance or all the other receptors that we talked about. This one tells us, and this is just to kind of understand, is what happens when people use different kinds of drugs. Opioids, so they're going to stimulate mu-opioid, reduction in GABA, increase in DA. We saw that. Alcohol, ethanol increases MOR1, reduces NMDA, okay, increase dopamine, increase GABA, and so on and so forth. So multiple activities. Some of them may look counterintuitive, but there are things in place which we may not know very clearly now. How do these things progress? We have looked at the stages, we have looked at the systems. We need to, kind of think that, well, this is there, but then, somebody takes alcohol. I mentioned this before, twice a week, nothing much happens. They may not take it for years together. In fact, they do not need it, but when they have it, they like it, things like that. So why in some people there is a progression to addiction? In some people, there is no addiction. So what determines the transition from drug experimentation to addiction? Or let's say sweet food intake to addiction to sweets, or experimentation with exercise and physical activity to exercise addiction, right? So first is genetics and epigenetics. Now it is very clear that since there are so many systems involved, there are so many molecules involved, there are so many proteins involved, there are so many things involved. Now each of these is under the regulatory activity of one's own genes and epigenetics. So since there are so many components in play, there are so many building blocks in play, any number of permutations and combinations of things going wrong can cause a problem. So what have we begun to understand? We have begun to understand this. Transcription and epigenetic modulatory events include regulatory and signaling genes like FOSB, NFB, CDK5, MEF2. Okay, these are some genes which have a developmental role, and if something is wrong with them, this can lead to addiction behaviors. What, when, where exactly? Well, this is completely out of our domain, because even the genetics and the epigenetics of, let's say, endocannabinoid system is being understood now. Endogenous opioid systems is understood now. How a person responds to stress, what is, how is stress encoded in our genetics so that we become vulnerable to stress. I mean, in the sense there is a chronic increase in CRF and things like that, right? So what we saw is there are several brain circuits involved in conditioning, reward sensitivity and incentive motivation, self-monitoring, regulation, mood, and interoception. Interoception is basically how internal physiological states are interpreted by our brain, because information is always coming from our external senses. So vision, hearing, taste, touch, smell, this is external input. But there are signals also coming from within the body. One of them is the gut-brain axis. Second is kinesthesis, right? So there's a lot of information. So this internal information, how is it processed? What is the end of it? Whether at the end of the process of internal information, is it a happy? Is it an okay sensation or not okay? Right? So this all all these kinds of things are involved in addiction. So from genes, which is, well, what we get proteins. Proteins form various structures. So whether it is molecules of neurotransmitters or receptors on membranes, anything that works over time, LTP, synaptic plasticity, over months to years, neuroadaptation. So this system sets, and over months to years of something, addictive behaviors. Right? So we have things at our disposal. It leads to this. Now, whether going back from here to here is possible, which doesn't seem to be very likely, because there is something called as settings. Right? So in this diagram, there are two things. One is this upper panel, upper part, which is the homeostatic, allostatic points. And the second is this increasing curved arrows. Okay, so what is this roughly? Let me try and explain. This is the normal mood state of an individual. This dark black line. Let's say I take alcohol here, state this point A. So I feel this good. Okay, so mood is okay. Baseline is taken as a normal mood state or a homeostatic point. This is called as the process of feeling good. But it is not a continuous process of feeling good. After some time, it's going to come down. So there are counter processes which will get it back to the baseline and little bit down. So this is a process. This is a counter process. A is a process. B is a counter process. So when I take the alcohol next time, okay, so let's say normally it comes till here. So this is what is allowed for us. Okay, we come back here. But when these counter processes come into play, they get this thing down quickly. So the next time I take alcohol, this process is already started acting. Why? Because the first one gave it a kick. Why? Because everything has to be in a homeostatic balance. In our body, in our physiology, nothing actually works if there is no homeostasis. So if there's a process, there's a counter process. If there's a loop, there's a feedback. Right? So the next time I take alcohol, since this counter process is already started, it is going to pull it down further and further. So at some point, this baseline actually shifts here. This is called as an allostasis. So it is not the homeostasis, but it is a new normal. So at this point in time, even if I take that alcohol, it doesn't give me anything, little bit of okay and lot of downer. So over time, over years, this homeostatic points, this point keeps on shifting down and down and down. And the negative, the low that it hits is lower and lower and lower. So this is called as the shift in allostatic states. And this is a kind of a more or less permanent change. Secondly, well, we can actually observe this clinically when we ask patients. If we ask them a good longitudinal history, we'll get all these things. But what happens? Let's say ventral tegmental area, nucleus accumbens. These are the stages that, these are the structures that are involved in the binge intoxication, means the pleasure state. Once they get activated, the activity is going to come down. The activity is going to come down. When it comes down, it causes stress, so increase in CRF. This is the fourth system that needs some mention. The first one being dopamine, the second one being opioids, endogenous opiate system, the third one being endogenous cannabinoid system or ECS or the endocannabidiol, and the fourth one is CRF. So what happens is, as it progresses, the pleasure that these systems can give is minimized till almost none. This means that these systems have got so much of plastic change, okay, that they are not able to give us the same kind of an effect. And once that effect is not there, that stress sets in. Stress, again, we need to understand in psychiatry and in physiology, is not that I have lost some money or I have met with an accident or met with an argument. This is how the systems, physiological systems, perceive and manage stress. And this is managed by increasing in CRF. So as CRF increases, along with this going down and down and down. But the different structures ventral tegmental area, nucleus accumbens, prefrontal systems, extended amygdala, dorsal striatum. In this pattern, they start, or let's say in this pattern, they undergo more or less lasting plastic changes, right? So continuous drug use cause neuroadaptations in CRF, in ventral tegmental area and prefrontal cortex. Finally, extended amygdala and recruitment of circuitry linked to the dorsal striatum, which is the negative emotional state and habitual drug seeking. Thank you so much. If there is any time for questions, we can take them, and I'll stop my share.
Yeah, Malay, that was an extremely wonderfully lucid talk on something so complex. I mean, our whole concept of addictive behavior per se has taken a U-turn now. And as you very rightly said at the outset, that motivational changes, motivational approaches, and all that is possibly good to an extent. But if you're talking about neuroplastic changes which have occurred inside, I think you need to have a completely new rethink about the whole thing. Which brings us to the point that I raised. I mean, how useful would this new understanding of systems and their manipulation, how would it really help in terms of management? Plus, there is another question I think that has been asked. I'll just check that out 1 second. Wait, talking about the phenotypic markers in childhood and or adolescence of future addiction disorder, the sense that could we catch them young?
Yes. Okay. So, and I think there is also the same, the person who has asked, the doctor who has asked about this phenotypic markers has also kind of given us an answer himself or herself, is how many opioid use disorder patients with childhood history suggestive of ADHD symptoms, right? So if we are looking at something which is incentive salience, dopaminergic, let's say dysregulation, then we need to, as sir said, start as early as possible. And the first observable thing that we are going to see in an individual is something like emotional dysregulation seen in childhood, which is a common component of ADHD, what we describe as ADHD. That's set. But what happens is, the moment we talk of ADHD, we are fixated on 2 points. One is the attention part, and second is the activity part. But what is more important in ADHD children is that since there is a basic, let's say, dopaminergic dysregulation, here dopaminergic dysregulation is focused on one thing, which is focus, which is attention. Right? One of the cognitive activity or action it observes is attention, interest. So when mothers are saying that my child seems to be disinterested, it means that there is something problematic with a dopaminergic tone in that individual. So what does happen with ADHD is that these things are there. Inattention is there. It's a cognitive marker. Hyperactivity is there, which is a behavioral thing. But what is also important, and which we do not really, sometimes, in fact, most of us see, but we don't do much about it, is the emotional processing in these individuals, emotional regulation with this individual. So many of these children will also come with temper tantrums, mood swings, alexithymia, and things like that, which are all emotional in nature. And probably in this, there is an underlying dopaminergic problematic functioning. So if you're looking at phenotypic things, then yes, we look at ADHD, but even before that, we are going to look at family history. So when a child comes to us with whatever disorder or no disorder, we need to ask a good family history, because they will get history of a lot of things. We'll get history of substance use in the family, we'll get history of disorders like this in the family, ADHD, we'll get history of disorders, mood disorders in the family, and so on and so forth, which are markers that there is a strong genetic component involved. That is how we need to pick up, because all said and done, as I said, that model is a model. Is it a complete model? No. Does it explain many things? It does explain many things. Does it give pointers to treatment? Yes, it gives pointers to treatment. The thing is that there are so many components, bits and parts, so many systems, that unless we have a thorough assessment of each and every system, some kind of let's say testing, whether it is genetic testing, whether it is an imaging testing, whether it is biochemical testing, which tells us definitely that this is what needs to be done. That is one. And secondly, we have something to treat that, which is not so simple. Now, one of the things that we are looking at, let's say when we look at the opioid system, is let's say naltrexone. We give it to many patients, which is good, which reduces the opioidergic tone. But what we have seen in the diagram is that this opioidergic tone in the body is 3 receptors, mu, kappa, and delta. So if we use naltrexone, it will block mu, means the hedonic tone, the mood tone will be slightly less. So if already that person has got dysphoria because of that second stage, the red one from that diagram, he might be a little bit more dysphoric, though the addiction will be there, the urge will be less, but it is one component. So again, we have something which we can use, but it is not a complete one because it does just only one thing, right? Now we look at other things. We look at, let's say, acamprosate, GABAergic. But then what it does is that it doesn't touch anything else. Now, in all addictions, it is not the same, same involvement of all the systems, some more, some less. So it may not really work in others. So that is where the trouble is. Now, we have got a lot of glutamatergic strategies, but even in very early studies, they have not been very successful, especially when it comes to those which have involved the metabotropic glutamate receptors. So yes, what we can do is we can try the best what we have. It is important to pick it up. Let's say if ADHD is there, then it's better that we start treating ADHD. Because if not, then ADHD does go into adulthood. Second, all of us know that untreated ADHD is associated with a lot of other things that can happen apart from ADHD in adulthood, including mood disorders, including addictions. So we treat them aggressively. That is the least we can do. I hope that answers the question. Then, I mean, of course, since this was not a topic which involved therapeutics and all, but yes, we have other modalities of treatment which are being tried in terms of transcranial magnetic stimulation, where we can manipulate the circuits without medications. But well, very, very few convincing results according to me.
Right. Right. Thank you, Malay. That was an absolutely scholarly presentation. Scholarly is a small word, but yes, you opened vistas of areas wherein we need to really rethink our whole process of looking at addiction. I think this has been of great help
Thank you.
to the program. And fortunately, Rashmin, you've been recording it. So I think it is there for posterity. Thank you so much.
Thank you.
Yeah.
Lovely, great. Thank you very much. So Malay, not only did you not disappoint, but you dazzled us, right? So I think you sell yourself too short, but most of us know how valuable your teachings are, and we are much grateful to you for that. And every single time I hear you, I just am more and more speechless because I I just know that I know so little when I hear you speak. So, but then it's something which is always enlightening and great to hear you again and again. And we always would want you back on this forum. So all our PG students and a whole bunch of senior consultants also now have started plugging in, especially when we have people of your caliber to teach us. Dr. Malay, Dr. Rajiv Palsotkar, Dr. Joita, many others were with us today. And it was really great for all of them to have also joined in to make this program the success that it is turning out to be. Once again, I thank Dr. Prasad for having taken the time out from his travels and his conference schedule. And of course, Malay is also in Bhubaneswar for most of us who don't know, and he was very kind to accommodate our request, and he is also doing it live online from Bhubaneswar. So I won't hold you both back. Please go ahead and enjoy your time in Bhubaneswar. But thank you once again, both of you, for having made the time for us. And thank you all the participants who keep encouraging us and who keep egging us on to bring to you this lecture series. And of course, thank you very much, Sun Pharma, for your unstinting support. So we promise to bring you back a whole new series of lectures this year as well. Many of them are already put up on the website, the prospective lectures as well. And of course, all the past lectures are also online. They are available for posterity on the website. So please feel free to peruse of all those lectures by just clicking on the video link in the past pages, past events page, right? Thank you once again, all of you. And I wish you all a good evening ahead. Thank you.
Thank you.
Thank you, Rashmi.
Thank you so
Great
much.
evening.
Thank you. Thank you. Thank you very much.